what's called a drug holiday and then perhaps reintroducing the medication. And that's these odd fractures, the long-term risk of subtrochanteric fractures. Any of you who've tried to persuade patients to take these drugs or remind them about how to take it will know it's complicated. They've got to take it first thing in the morning on an empty stomach with a glass of water, sitting upright or standing, and then they've got to wait for 20 minutes, 30 minutes before they have their breakfast. That's not very popular medication. It's inconvenient. People don't, they want it with a cup of tea. As soon as you put any milk in the tea, you won't absorb any of it. You take it with the rest of your medications after breakfast, completely useless. So this is a problem, and if you're dealing with frail elderly who may be forgetful or have a degree of dementia, they're just never going to remember how to take these medications properly. And as has already been alluded to, I think, by Simon earlier on, that chronic therapy, chronic disease management, adherence to therapy after 2 or 3 years, many people aren't actually taking the medications with any regularity at all. There's a small number of people who don't respond to the bisphosphonates, and you can't use it in people with bad renal disease, and that's an eGFR worse than 35. So these are that gives you an idea of who you might want to consider for second-line treatments. By far the commonest group is people who get GI toxicity, GI problems, indigestion, constipation, abdominal pain, heartburn after they've taken their once-a-week tablet. And that's a very common problem. Patients who are unable to comply or just don't want to comply with the complex administration, and there's just some people who say, I can't be bothered taking this, and there's others who just won't remember. There are, as I said, a few non-responders, and people with renal disease are the ones who you might want to consider for alternate treatments. And these are the alternate treatments that certainly we're using in the UK. And I just very quickly want to run through them. They're all effective to one degree or another. PTH, or parathyroid, is very restricted for use because it's extremely expensive, and in the UK the government pays rather than the patient. But we would still only use it for very severe osteoporosis in people who are fracturing and can't tolerate the oral drugs. It's our only anabolic agent. You get a spectacular increase in bone density. I've seen bone density in people's spine increase by 25% in 2 years with PTH injections. So it's spectacularly effective, and it also reduces pain for people with multiple spinal fractures. But the patient has to give the injection themselves, and it costs about $7,500 for the 2-year program. And I imagine that would make it prohibitive for all but the richest in India. Strontium ranelate is another agent. It's in the same table, in the periodic table, the same column as calcium. And there is evidence in the over 675s that this will reduce fracture risk. But it carries all the problems of the bisphosphonates. It's got to be taken on an empty stomach, but you need to take it every day. The recommendation is you take it before you go to bed with a glass of water, and the patients will then say that they wake up in the morning running to the toilet because they've got diarrhea from the preparation. And I tend not to use this agent very much. I don't find it tolerable or tolerated well by patients. And that gives us the last 2 agents, which are the ones that probably are the main agents that we're now using for people who are unable to tolerate oral therapy in the UK. One is a once-a-year infusion of Zoledronate or zoledronic acid. We use this already for Paget's disease. It can more or less cure Paget's disease. It actually gets rid of malignant hypercalcemia from cancer very, very effectively. And you give it as a once-a-year infusion. So somebody comes into clinic for 20 minutes once a year for 3 years, and that controls their bone mineral density and has major benefit for 6 years. So 3 20-minute sessions. Very effective. People can feel a bit viremic. They can feel a bit arthralgic or myalgic for a day or 2 after the injection. They usually just take something like paracetamol or aminoacetylene. But essentially, I've never had a patient decline to have this treatment again. And we've been using this now for about 8 years. This is the Horizon study, and just demonstrates the risk reductions that you see. And what I would like to point out is the efficacy of this is probably no better than the oral tablets. So we're looking again at about 70 to 80% reduction in vertebral fractures, 40 to 50% reduction in hip fractures, and about a 25% reduction in non-vertebral fractures. So this is no better than oral bisphosphonates, but if you give the patient this treatment, you know it's in the system for the next year. You're not having to rely on them having to take it, and if people are intolerant to the oral tablets, this way they can take the medication and get the benefits without the side effects. And there is also one study, this was the only randomized controlled trial I know of in people after fractured hips. And this is for men and for women, so it's one of the only trials in men as well as women. And they gave IV Zoledronate yearly after the people had sustained their fracture. So a hip fracture, and another slide would demonstrate a significant reduction in on all fracture types in people who've already sustained their hip fracture. But surprisingly, this study also showed a mortality benefit for people treated with Zoledronate. So in fact, there was almost a 30% reduction in mortality from treating people effectively with this agent. And that has led some countries to adopt a model where they actually give IV Zoledronate within a few weeks of somebody sustaining their hip fracture. That's not what's happened in the UK, where we tend to use oral bisphosphonates first, and then only this intravenous preparation if people are unable to tolerate it. And finally, the new kid on the block, relatively, it's been out about 3 years, is a monoclonal antibody against a particular signaling system in the bone. The drug is called Denosumab or Prolia. I'm not sure if it's available in India at the moment. Anyone? Available. And this is very convenient for patients. It's a 6-monthly injection. We give all our patients in the UK a flu jab every year. You can more or less the GPs could be giving this drug as a 6-monthly jab in their arm up at the health centre, or coming up to a polyclinic for a jab. It's very convenient. I've been using it for about 2 or 3 years. I've yet to find a patient who's had any side effect, any problem with the injection site. You can use it in people with dialysis. I've got 2 patients on dialysis, so the renal function is irrelevant. And the cost, certainly in the UK, is similar to the other second-line treatments. All of them tend to come in at about $500 a year as the cost in the UK. But I know that your drug costs are very different from ours, so obviously you'll know better than I do about that. Denosumab, again, this is just to demonstrate efficacy, and I would say its efficacy is the same as the bisphosphonates. So the same sort of fracture reduction we see at the 3 sites. But there has been sub-analysis to look at over 75s, and this, if anything, shows Denosumab showing a bigger reduction in fracture risk in the over 75s than in the younger population. And that's unlike data in IV Zoledronate, which has been unable to show that. So, a picture of Edinburgh in the background and one of India's most famous marathon runners in the foreground, but this is really just to finish off, and really just, I suppose, to a bit of a rallying cry. Now, obviously, the incidence of osteoporotic fractures in India is going to increase dramatically in the next 20 to 30 years. You have an aging population, you cannot avoid that. Older people in India, as in everywhere else in the world, deserve a strategy to try and minimize the numbers of fractures they're going to have. And that means public health strategies and medical strategies. What we find now is that age-related fracture risk is beginning to fall in North America, in Australia, in the UK, but also in Asian countries. I've recently refereed a paper from Hong Kong, and I've seen data from Singapore showing that their age-related hip incidence is now beginning to fall. So they have peaked and are starting to come down the other end. Now, those Singapore and Hong Kong have a higher prevalence of the elderly in their population, but it shows that if you have the right strategies, you can't prevent this large. You might be able to affect the height of the increase. So what can India do to minimize the fractures? So we've already talked about public health measures, particularly around diet. You also need normative data for DEXA scanning, and there is work undertaken for that, and the people who deal with FRACs tell me that there will be normative data for DEXA scanning for Indian populations within the next year or so. You need adequate provision of DEXA services if you're going to have an evidence base to treating people who you think have osteoporosis. You need to confirm the diagnosis. I would say that you should be starting to target those people who've had their first fracture. So secondary prevention after fracture is your key target population. And then case finding for other areas. Use once weekly oral therapy with calcium and vitamin D. It works, it's cheap, it's effective. You do also need, obviously, hospital provision for the more complicated patients, and also for those patients who don't tolerate the primary treatments, bisphosphonates. In the UK, primary care now manages, they often request the DEXA scan, or we request it and tell them their patient is osteoporotic. They'll treat the person with the bisphosphonate. We now get referred to people who don't tolerate the bisphosphonates or have problems or have other reasons. But that has taken about 20 years to get to that point. You need protocols which work for the more expensive agents. And finally, I think we've already seen that you need to build links to falls. And John's already said, if you're a falls doctor, you should be thinking about bones. If you're a bones doctor, you should be thinking about falls. And if we're looking at things like nutrition and aging, then we also need to in with other strategies, exercise programs. That paper from Hong Kong, they, as well as dealing with fracture intervention, they're dealing with falls by having a government-sponsored program for Tai Chi, where they're actually trying to encourage all people over 65 to enroll in Tai Chi classes, and are actually promoting that as a public health measure. So what we need to do, and all of the world is struggling with this one, is to try and tie together these different strategies and make them all work. Thank you very much.
Thank you, Dr. Donald. We'll now take questions on this topic. Yes.